First, I want to thank the organizing committee, Dr. Khalil, for the invitation to be here. It's a pleasure to be participating in this association meeting. I have no conflict of interest, and in comparison to the earlier talks, which is designed to touch the lives of many patients with heart failure, heart transplantation is reserved for a selected group of patients. It was December 3rd of 1967 where the first human heart transplantation was performed in South Africa. And this is a photograph of the operating room, preliminarily very primitive compared to the current standards. About a week later, in fact, 47 years ago, exactly yesterday, this was the front page of the local newspaper. I have to use the mouse, okay? On top, you will see the recipient, the first recipient of heart transplantation with his wife. And down here, you actually see something that we currently consider unheard of, which is the picture of the donor. And down here, you see the two kidney recipients. And of course, at the bottom, you see the smiling surgeon who performed the first human heart transplantation. As you well know, it was Christian Barnard who actually trained with Dr. Shumway for about 6 months at the University of Minnesota before returning back to South Africa, where the laws of brain death was not as well established, and he was actually able to do the first human heart transplantation. Christian Barnard went on to continue practice heart surgery for about 10 years or so, and then he developed arthritis in his hands, so he could no longer operate, and he went in to become a dermatologist and developed some anti-aging creams and so on and so forth. He passed away in Monaco about 10 years ago. The father of heart transplantation is Norman Shumway. As many of you know, he was the one who spent many years developing the technique and did the first human heart transplantation in the United States about a month later in January of 1968. It continued to be a experimental procedure for many years until cyclosporin came about and heart transplantation became an effective form of therapy for selected patients with end-stage heart disease in the early 1980s. And as you can see, this is a International Society for Heart and Lung Transplant Registry, which is a voluntary registry across the world, but it shows that the number of heart transplants in the world that voluntarily contribute to this database has remained steady, somewhere around 4,000 to 4,500. What do we currently consider the indications for heart transplantation? Virtually any patients with class 3 or 4 heart failure symptoms with objective evidence of impaired functional capacity, the peak oxygen consumption of less than 14 cc's per kilogram per minute. Very infrequently, patients who have refractory angina that is not amenable to other forms of revascularization, other forms of therapy, refractory ventricular arrhythmias, of course, end-stage congenital heart diseases, and very infrequently patients with restrictive cardiomyopathy or hypertrophic cardiomyopathy. What do we consider as current contraindications? Patients who have significant pulmonary hypertension that is irreversible. And I want to emphasize that because there have been new ways of managing patients with pulmonary hypertension that can be candidates for heart transplantation. Patients with active infection. We currently consider hepatitis C as a contraindication in most transplant centers across the world. There are a few programs that offer heart transplantation to HIV positive patients, and that is within an experimental setting. Patients who have end-stage extracardiac organ disease, such as end-stage liver disease. Patients with end-stage renal failure, we now offer dual organs, kidney and heart transplantation together, preferably from the same donor. Morbid obesity, severe diabetes, peripheral vascular disease, and recent strokes, presence of active neoplasms, with the exception of maybe skin cancers or prostate that's of low grade, are usually considered contraindications for heart transplantation. What about the diagnoses for patients who undergo heart transplantation? If you look at the circle on to your right, you can see that dilated cardiomyopathy is becoming the most common indication for heart transplantation. Coronary artery disease or ischemic heart disease is the second. There's still about less than 5% of the patients who undergo redo heart transplantation. The donor allocation varies across the world. In the United States, there is basically a three-tier system that is based on severity, the condition of the patient, how bad they need it, the distance from where the organ has become available. Time also matters, and obviously the donor and recipients have to be matched based on size and the blood type. What are the donor guidelines? What are the characteristics of a donor that we consider acceptable? Usually we would like the age to be younger than 55. The oldest age that we have used is 68-year-old donor that required some additional intracardiac procedure. As I said, we for HIV and hepatitis B surface antigen positives, with the exception of the immunized donors, we consider those active infection and do not transplant those donors. If a donor has a severe infection, has an extracranial malignancy, has severe chest trauma and cardiac contusion, presence of significant coronary disease, we would like to make sure that the ventricular function is normal on minimal dose of inotropes, and we make sure that the body size is matched for the donor and recipients. We like to keep the ischemia time less than 5 hours, if possible. As you can see from the slide, the age of the donors is steadily increasing. In the United States, it's now over 30. In Europe, it's even older, but we are accepting more and more older patients. We know that the donor age has an important influence on the survival of the recipient. We know that the donors over the age of 55 don't do as well as the younger donors. And the issue that's most relevant with the older donors is the issue of the ischemia time. We know that the patients who are older, namely 60 years of age, once you start reaching beyond 4 or 5 hours of ischemia time, the mortality of the recipient, the odds ratio, becomes significantly higher. What about the surgical technique? This is something that most of the surgical community is fairly familiar with. As you know, the original surgery was designed as biatrial procedure, but I think we have all found out that if we do a bicaval anastomosis, by that I mean connecting the superior vena cava to the superior vena cava of the donor and the inferior vena cava to the inferior vena cava of the donor, we have a better function as well as structure of the donor heart. We know that this bicaval technique has less disruption of the atrial anatomy, results in better right ventricular function, and has less valvular complications. If this is the donor heart in the donor, the process involves transecting the aorta, SVC, IVC, and the pulmonary arteries. The pulmonary veins are resected. The heart is explanted. This is what the donor heart would look like. And this is what the recipient chest would look like, where you have the left atrium connected with the pulmonary veins, the pulmonary artery, the aorta, SVC, and IVC. This is how the donor heart arrives. We connect all the pulmonary veins, and then the anastomosis is begun with the approximation of the left atrium, followed by the pulmonary artery, aorta, SVC, and IVC. And this is the final product, which is a heart that is connected via the two cava. What about the unique features of perioperative management? For virtually all of the heart transplant patients, we prefer a left atrial line, and the reason for that is that the PAD, the pulmonary artery diastolic pressure, in many of these patients is not quite reflective because of the long-standing pulmonary arterial hypertension. CVP is monitored for several days after transplantation to ensure that the right heart function is okay. We invariably use pulmonary vasodilator, nitric oxide, after heart transplantation to ensure that the donor heart function, and especially the right ventricle, remains normal. Invariably, all the heart transplant recipients receive inotropic therapy for a minimum of 48 to 72 hours. The immunosuppression consists of induction therapy, calcineurin inhibitors, antimetabolites, and the steroid, the triple immunosuppressive therapy that everyone is familiar with. When we look at the induction therapy, we realize that only half of the centers reporting to the international registry actually use induction therapy. And for those centers that use induction therapy, the IL-2 receptor antagonist is the most commonly used agent, followed by the ATG, and pretty much OKT3 is no longer being used as the induction therapy after human heart transplantation. And when we look at the survival as a function of induction versus no induction, it really does not matter. We generally prefer to use induction therapy in patients who have renal insufficiency for the first few days so that they're spared from the calcineurin inhibitors. What about the postoperative managements? There are several objectives. One is to prevent rejection. Second is to prevent development of cardiac allograft vasculopathy or chronic rejection. We treat many of these patients with prophylaxis for a variety of infections that they're susceptible to. Many of these patients develop hypertension or diabetes. These patients are also required to be available to be coming to clinic on a very regular basis. And it's for that reason that the social factors are paramount importance for selection of patients for heart transplantation. We require that they come to clinic twice weekly for the first month, once weekly for the first month or so, 2 months, followed by the Q month or every month after that. When it comes to rejection, we have a variety of ways to assess rejection, and including echocardiogram and endomyocardial biopsy. And lastly, it's also important to emphasize that most of these patients develop chronic rejection. As a result, they have to undergo routine follow-up studies. What about the rejections? Well, how do we classify the rejections after heart transplantation? The rejection is usually manifested with non-specific symptoms of being tired, not having the energy, occasionally low-grade fever. Clinically, it's characterized by abnormal rhythm. Patients develop signs and symptoms of heart failure and systolic dysfunction. As you well know, the cellular rejection is diagnosed with endomyocardial biopsies and pathologic examination of the biopsies. Well, based on the ISHLT criteria, there are 4 major classes that, depending on the patient and the clinical condition, determines who should get what in terms of the therapies. More recently, humeral rejection has become a better known phenomena and a more commonly diagnosed condition after heart transplantation. And it's a very difficult clinical entity to diagnose, but it occasionally requires endomyocardial biopsy, which is suggestive, not diagnostic, in the correct setting of the presence of donor-specific antibodies or a variety of other conditions may be suggestive of humeral rejection. What do we do in terms of the management of these of patients after heart transplantation? For patients whom we know that they have cellular rejection, if they are asymptomatic, our general rule is that we ensure that the immunosuppression is optimized and occasionally we administer a bolus of steroids or consider switching to an anti-proliferative agent. For humeral rejection, nobody knows, in the presence of antibodies, but in absence of symptoms, what to do. And this is currently the subject of several ongoing clinical trials. In patients who have cellular rejection based on the endomyocardial biopsy and have reduced EF, we are fairly familiar what to do. These patients need to have augmented immunosuppression, be it either steroid boluses or changing their medications. In patients who have reduced EF and humoral rejection, we also treat with steroids or sometimes consider immunoglobulin, or in selected cases consider plasmapheresis. And lastly, for patients who have evidence of heart failure or shock, who have either cellular or humoral rejection, we pretty much do everything we can. Throw the whole kitchen sink at them in terms of all the therapies for immunosuppressive medications that are currently available. This is a busy slide and hard to read, but I just want to emphasize these lines refer to the number of times the patient has to come to clinic. This is a requirement for our program in terms of their visits after heart transplantation. And we routinely perform endomyocardial biopsies during the first year. After the first year, it is clinically indicated. We only perform these procedures after when there is an indication from a clinical perspective. This is a slide that shows the 1-year survival after heart transplantation. Generally speaking, based on the ISHLT registry, the 1-year survival is about 88 to 90%, which means that 9 out of 10 patients at 1 year are alive after heart transplantation. This shows a longer-term survival of heart transplant recipients. It's sobering to say that for someone who undergoes heart transplantation in 2014, the median life expectancy is 11 years. For a patient who has undergone heart transplantation and has survived to the first year, the median expected life survival is 14 years. So half of the patients who have undergone heart transplantation and are alive at 1 year are likely to live beyond 14 years, which proves the point that we have come a long way in the past 47 years. Again, this is a busy slide, and I think I just want to highlight a few things in terms of the predictors of who survives after the first year. As you can see, the most important predictors are the patients who have ventricular assist device, on ECMO, on ventilator, or pulsatile bivans. Those are the patients that are highest risks. But pretty much everything else, in terms of the durable assist devices, the mortality, the odds ratio is less than 1.5. What about the complications after heart transplantation? And there are several. One can see that after 5 years, virtually all of the patients have hypertension. About half of the patients have renal failure, and about 87 or 90% of them actually have high dyslipidemia, with about a third having diabetes. Cardiac allograft vasculopathy is the chronic rejection that occurs in vast majority of the patients. It's diagnosed with an annual angiogram, and we usually now perform IVUS, intravascular ultrasound, routinely in all patients who undergo routine surveillance angiograms. The management is difficult for established CAV. It requires changes in the therapy, consideration for proliferation signal inhibitors, statin therapy that's now routine, adding Plavix versus, most of these patients are already on aspirin. And then the issue of revascularization becomes a difficult issue because it has not been shown to be of great help in patients with cardiac allograft vasculopathy. This is a slide shows that once you have the diagnosis of CAV, when you compare the red line to the yellow line, it is substantially lower survival. What about malignancies after heart transplantation? There are a variety of them, and most of them are post-transplant lymphoproliferative disorders. And among the risk factors is EB-positive donors, the patients who have received multiple doses of steroid or immunosuppression, and treatment basically consists of reducing the immunosuppression and augmenting different types of immunosuppressive therapy. And this is a slide of the heart transplant recipient as a function of patients who have had prior malignancy. We know that those who develop malignancy after heart transplantation have a significantly decreased incidence of survival. Let me conclude by saying a few words about where we go from here in the field of heart transplantation. There are several areas of the frontiers of the field. One of them is the donor selection and donor utilization. We know that vast majority of the patients with end-stage heart disease do not have the benefit of heart transplantation because there's just not enough donors. One possibility is to try to expand the donor pool, and I know in Kingdom it's very difficult to try to expand the donor pool. However, in the United States, there is more than 10,000 consented kidney donors, and one of the ways that we have considered expanding the donor pool is instead of keeping the donor heart on ice, which we currently do, we have thought about the possibility of actually taking the heart out, putting it on a machine that continues to perfuse the donor heart with the donor blood. And this is, can I have the first video? That's it. There we go. I think this is a brief video of a new technology that is now under investigation in the United States, where we actually take the human heart out and put it and hook it up to this machine, to this device. This device has the donor blood circulating through the heart. It has a pump, it has an oxygenator, it's a portable device, and it keeps the donor heart beating alive during transport. We actually have ways that we can potentially keep the human heart alive outside of a human body on a device during the transport. The goal of this technology is to potentially increase the number of donors available, and most importantly, allow us to use this technology, this platform, to change the heart. What if we could potentially take the donor heart and convert all the AB, B, and A blood type to O blood types? Or we could potentially pharmacologically or genetically modify this human heart so that it would be a better organ at the time of transplantation. Other frontiers of heart transplantation include improvements in immunosuppression, so-called personalized immunosuppression based on the genomics of the recipient, non-invasive immune monitoring so that we don't have to do endomyocardial biopsies. We can just draw a blood sample from the patient and use that to detect rejection. And obviously the holy grail of heart transplantation, as well as any solid organ transplantation, is development of donor-specific tolerance, and that may be a few years away from here. Thank you very much for the attention.